Patellofemoral pain syndrome by Jody Schultz and Kayla Ferris. What is patellofemoral pain syndrome? Patellofemoral pain syndrome is characterized by anterior knee pain, both pre- and retropatellar, with little evidence of structural damage. Pain often occurs during highly loaded knee flexion and extension and can be accompanied by impaired function. Exercises with high impact knee extension and flexion also can cause pain. The causes of patellofemoral pain syndrome are often ambiguous and related to biomechanical and structural imbalances. Treatment options include exercise programs with the inclusion of lower extremity, hip, and trunk musculature, patella bracing, and orthotics. A commonly asked question is what is the difference between patellofemoral pain syndrome and chondromalacia patella? Chondromalacia is the actual fraying and damage of the underlying patellar cartilage and is treated surgically with arthroscopy. Arthroscopy is not a choice of treatment for patellofemoral pain syndrome without any severe structural changes. Severe structural changes is often related to chondromalacia. The main causes of patellofemoral pain syndrome are often due to patellar maltracking. Here is a video to show you the anatomical changes that occur due to muscular imbalances.
In a properly aligned knee, ligaments and tendons attached to the tibia and the quadriceps hold the patella as it glides comfortably in the femoral groove. Force between the patella and the femur is evenly distributed on the surface of the femoral groove. Most important in assuring proper patellar alignment in the femoral groove is the balance between the soft tissues, principally the muscle called the VMO and the lateral retinaculum. Imbalance between these tissues usually causes one of two principal types of malalignment, patellar tilt or lateral glide. Both conditions involve a weak VMO and a tight lateral retinaculum. Left untreated, the condition worsens, causing a lateral soft tissue contracture with a corresponding weak VMO. Hence, the patella is effectively locked out of its normal tracking position. Two main problems result from this abnormal positioning of the patella. First, force between the patella and the femur is now shifted and concentrated onto a smaller area of the lateral condyle of the femur. That increased pressure transfers into the nerve-rich subchondral bone, creating pain. Second, the lack of contact on the medial articular cartilage will cause chondromalacia, or a softening of the cartilage. To decrease pain, greater surface contact area must be restored in the joint. To correct the malaligned patella, balance must be restored by strengthening the VMO and stretching the lateral retinaculum.
Risk factors that may contribute to patellofemoral pain syndrome include patellar dysplasia, such as patella alta, tight patellar retinaculum, abnormal patellar tracking, tilt or rotation, abnormal patellar alignment relative to the femur. This is due to that increased Q angle that we see in women from outside of 13 to 18 degrees, a crossover gait, excessive genovalgum or varum at the knee, muscle weaknesses in our VMO, hip abductors, lateral rotators, and ankle dorsiflexors, a muscle imbalance from our quad to hamstring ratio, often seen in women, excessive tibial torsion, foot malalignment such as excessive pronation supination at the foot, muscle hypermobility in our quad, hamstring, and IT band, trauma to the patella such as a direct blow or a dislocation, abnormal repetitive stress to the patella such as an increase in our running routine, training shoes that are worn or broken down, and excessive pelvic tilt, anterior, posterior, or medial lateral. Incidence of patellofemoral pain syndrome. 22 of 1,000 people are affected with patellofemoral pain syndrome each year, often affecting teenagers, athletes, and women. Women are twice as likely to be affected when compared to men. This is due to that increased Q angle that we spoke of earlier. Because of their broader pelvis, the femur generally migrates inward at an increased angle, making the distal end of the condyles parallel with the ground. As the quad contracts, the angle tends to straighten, which forces the patella laterally. Client profile. The client is a CIS level women's basketball player who is 20 years old and a point guard. She has been experiencing knee pain for 1 month now, gradually increasing as the season progresses. Chondromalacia patella has been ruled out by diagnostic imaging, and she has been diagnosed with patellofemoral pain syndrome. Set standards and rating scales we used for this assignment are knee extension of 0 and flexion of 140, a rating of perceived exertion scale from 6 to 20, and a pain scale from 0 to 10.
Upon assessment, our client is presented with pain in her right knee with flexion and extension in both active and passive ranges of motion, rating her pain as 6 out of 10. She has reduced extension in her right knee to 5 degrees due to pain and reduced right knee flexion to 115 degrees due to pain. Pain increases with prolonged sitting or when ascending and descending stairs to a 5 out of 10. Pain also increases towards the ends of games and practices to an 8 out of 10. Strength in the right gluteus medius and right quadriceps, specifically the VMO, was rated a 3 out of 5. Slight VMO atrophy was noted on the right side. A tight iliotibial band on the right side is causing lateral patellar tracking in the right knee. She is unable to take part in regular games and practice situations. Our rehab goals for the acute stage are to reduce pain with both active and passive range of motion in flexion and extension to 3 to 4 out of 10 using modalities such as ice. We'd like to increase right knee extension to full or 0 degrees pain-free and increase right knee flexion to 125 degrees pain-free. We'd like to reduce pain with prolonged sitting or when ascending and descending stairs to a 2 out of 10. We'd like to increase isometric resistance strength in the right gluteus medius and the right quadriceps to a 4 out of 5. We'd like to improve lateral patellar tracking in the right knee by foam rolling and stretching the iliotibial band on the right side. We would also like our client to observe regular practice times and communications with the team to maintain psychological well-being. 2 exercises that we would prescribe for our acute stage are side clams to target endurance in the gluteus medius. This will be completed 15 reps for 3 sets. The second exercise is resisted bike with a race seat. This targets strength, range of motion, and coordination. This exercise will be completed for 10 minutes at an RPE of 12 to 14. For this exercise, we'll have the client adjust the seat so that they are unable to fully flex and extend their knee. This is roughly 90 degrees of flexion and 5 degrees of extension, making sure the resistance is set appropriately and does not elicit any pain. This allows the client to work through and maintain a pain-free range of motion. For side clams, we'll have the client lay on her side with the working leg on top, keeping legs bent at 60 to 90 degrees and feet and ankles together as she abducts at the knees, making sure the ankles remain in contact the entire time. This will target muscular endurance in the gluteus medius. In order to maintain the whole body throughout the rehabilitation program, we will have the athlete complete skull crushers, Bosu push-ups, Pavlov press, Mason twists, arm bike, reverse flies, easy curl 21 guns, leg lifts, and back extensions during the acute stage. Upon reassessment in the recovery stage, weeks 1 to 2, our client is presenting with pain in the anterior medial right knee with flexion and extension with both active and passive range of motion of 3 to 4 out of 10. She has reduced active range of motion in her right knee with flexion at 125 degrees due to pain. Pain in her right knee increases with prolonged sitting or when ascending and descending stairs to a 2 out of 10. Strength in her right gluteus medius and right quadriceps has been rated a 4 plus out of 5. Lateral patellar tracking in the right knee is still noted due to a tight iliotibial band on the right side. She is still unable to engage in regular game and practice scenarios. Our rehab goals for this stage are to reduce pain with active and passive range of motion of right knee flexion to 2 out of 10 by using modalities such as ice. We'd like to maintain active and passive range of motion in right knee extension to full or 0 degrees. We'd like to increase active and passive range of motion in the right knee flexion to 130 degrees pain-free. We'd like to reduce pain with prolonged sitting or when ascending and descending stairs to a 0 to 10 and increase strength in the right gluteus medius and the right quadriceps, specifically the VMO, to 5 out of 5. We'd like to continue to improve patellar tracking in the right knee by foam rolling and stretching the iliotibial band on the right side. We now ask our client to observe regular practice times and communications with the team to maintain psychological well-being as well as assisting coaches during practice. We'd like her to begin jogging at an RPE of 9 to 11 and jumping activities at an RPE of 10 to 13. Two exercises that we chose for the recovery stage were lateral step downs, which target strength, coordination, proprioception, and balance. This exercise will be completed 3 sets of 10 reps. The second exercise is a stabilization retro lunge, which will target endurance, proprioception, coordination, and balance. This will be done 3 sets of 20 reps. Both of these exercises target strength and endurance in the gluteus medius and maximus and the quadriceps, specifically the VMO, as well as the hamstrings and the core. They'll focus on maintaining stabilization and single leg balance.
To perform the lateral step downs, have the patient standing on a box with one leg while keeping their non-working leg straight. Cue the patient to push their butt backwards towards the wall instead of lowering their body. This will prevent the knee from migrating in front of the toe. While performing the exercise, it is also important to look for medial kneeing in, as this will cause unwanted stresses on the knee. Tempo can be altered for this exercise. For this example, we used a ratio of 1 to 1. To perform the stabilization retro lunge, have the patient start with their feet shoulder width apart. Cue the patient to alternate a backward lunge, keeping their knee in front of their toe. Here, a resistance band is used to cue the patient not to knee in during their exercise, which is a common mistake for patients due to their weakened VMO.
Along with observing regular practice and weight room attendance, we will have the athlete complete TRX rows, tricep dips with weight, lat pull downs, core tabletop with medicine ball, biking with patellar taping, shoulder IYs and T's, bicep curls, incline chest fly, and TRX pike with tuck in order to maintain the entire body throughout the recovery stage. Upon reassessment in the functional phase, weeks 2 to 4, our client is presenting with pain upon flexion in the right knee for both active and passive range of motion, rating pain at 2 out of 10. She has reduced right knee flexion to 130 degrees due to pain and is unable to complete regular practice and game routines. She can jog at an RPE of 9 to 11 and is completing jumping activities with an RPE of 10 to 13. She has reduced cardiovascular endurance, roughly 10% decrease in VO2 max, and has a low perceived performance in agility activities and is psychologically unprepared for gameplay. Our goals for the functional phase are to reduce pain with both active and passive range of motion and right knee flexion to 0 out of 10 using modalities such as ice. We want to maintain right knee extension to full or 0 degrees pain-free and increase right knee flexion to 135 degrees pain-free. We want to maintain strength in the right gluteus medius and the right quadriceps, specifically the VMO, to 5 out of 5. We want to maintain proper patellar tracking in the right knee by foam rolling and stretching the iliotibial band on the right side. We want to maintain pain-free ADLs such as stairs and prolonged sitting. We'd like to increase VO2 max roughly 5% and integrate the athlete into restricted practice routines such as limiting running to an RPE of 14 to 17 and jumping to an RPE of 16 to 18. Two exercises that we chose for our functional phase are lateral hops on a BOSU to target strength, endurance, proprioception, and balance. This will be completed 3 sets of 12 reps. The vertical jump on a Vertimax will target power, strength, speed, proprioception, and coordination. This will be completed 3 sets of 5 reps at 16 to 18 RPE with 5 minutes rest between sets.
To perform the lateral hops on the BOSU, have the patient first test the unstable surface. When they are comfortable, cue the patient to laterally hop onto the surface of the BOSU, stabilizing in a loaded position for 2 seconds before pushing off the BOSU. Before adding medicine balls or basketballs to the exercise, make sure the patient is landing the hop with proper form. To perform the vertical jump on the Vertimax, connect both the upper and lower body systems using the belt and wrist straps. Ensure the athlete is using both upper and lower body during the vertical jump exercise while watching for correct landing mechanics. The Vertimax is used to apply resistance to all critical components of the athlete's jump, producing overall gains in performance. The Vertimax also uses contractible resistance that never slackens. Therefore, resistance does not completely diminish during the lowering phases of the jump. This leads to more power development due to decreasing offloading of the resistance during the jump. This principle can be used in the final weeks of the functional stage as well as the return to play stages.
At this stage, our athlete will begin low-intensity practice with patellar taping. They'll complete battle ropes, weighted bench dips, plank, kettlebell side crunch, biking, seated hammer curls, reverse easy curls, side plank dip, and dead bugs in order to maintain the whole body. Upon assessment of a return to play stage, our client is presenting with reduced cardiovascular endurance, roughly 5% decrease in VO2 max, low perceived performance in agility activities. She is psychologically unprepared for gameplay and is running at an RPE of 14 to 17 and jumping at an RPE of 16 to 18. Our goals for this stage are to maintain pain-free active and passive ranges of motion in both flexion and extension, maintain proper patellar tracking in the right knee and by foam rolling and stretching the iliotibial band on the right side daily. We want to maintain pain-free ADLs, increase cardiovascular endurance to pre-injury VO2 max, maintain strength in the gluteus medius and the VMO to a 5 out of 5, increase agility and psychological preparedness to game level using game-specific drills and scrimmage scenarios. We would like our athlete to be able to complete sprints at an RPE of 17 to 20 and able to complete jumps at an RPE of 18 to 20. Two exercises that we chose for the return to play stage are the agility ladder and the T-drill with finish. Both of these activities target speed, power, proprioception, coordination, and agility. Both of these sport-specific activities can be adjusted according to the goal that they are trying to achieve. When performing agility ladder activities, make sure the athlete is maintaining an athletic position as they move through the pattern. Make sure their biomechanics is intact as they move as fast as they can. These exercises can be varied, and the use of different patterns is often encouraged to vary the ability of the athlete. When completing the T-drill with finish, ensure the athlete is maintaining a low athletic stance as they shuffle between cones. Once they get to the center cone, ensure they are exploding into their sprint and using the power to force their body up towards the basket. At this stage, our client is completely integrated into regular practice when using patellar tape. In order to maintain the whole body, they will go on the treadmill for 20 minutes. They'll use a TRX bicep curl, chest fly, mount climbers, walkouts with push-ups, battle ropes on BOSU, TRX tricep extensions, BOSU plank, shoulder lateral raise and front raise, leg throws, and medicine ball chops. These are other exercises that can be used on a Vertimax during the return to play stage for a basketball player.
For our class discussion, we'd like you guys to get into groups and discuss times you've diagnosed patellofemoral pain syndrome in a clinical or field setting, how it presented, their perceptions of pain, their locations of pain, or treatment options, or anything else you guys would like to share.